Good morning, everyone. So we'll start off with our neuro ophthalmology instruction course, Demystifying the Neuro-Ocular Highway. So here we are actually providing a structured and practical overview of disorders which affect the movements of the eye, starting from the muscles, the neuromuscular junction, to the cranial nerves and to the supranuclear pathways. So we'll go with the first talk. Dr. Monisha, she's a senior consultant at Ahalya Hospital, Palakkad. So she will be talking on muscles and myopathies and the eye. Monisha, please.
So at the outset, I would like to thank Dr. Remya for including me in this IC and KSOS for the opportunity. So I'll be speaking on ocular myopathies. So often we come across such a patient who comes into our OPD with ptosis and extraocular muscle restriction like this. Now we pause for a moment and then think whether it's a nerve palsy, it's a nerve problem or a muscle problem or something entirely different. So here is a complex case scenarios where you will get an idea of how to deal with each of them one by one. So this is a broad classification. So it looks intimidating, but it's not. So we can start with congenital or genetic pathology. The most common probably would be the CPO or the extraocular muscle fibrosis, like the Browns or the types of other types of CFEOM. Then we have the ocular myasthenia, which is a neuromuscular junction disorder, and acquired myopathies like the thyroid, which is the most common, and of course the systemic and the infiltrative disorders like the sarcoidosis and amyloidosis. So coming to this lady, this is the first case. So she's a 55-year-old female who came with drooping of eyelids occasionally, and she had a diurnal variation, and ptosis sometimes was in the right eye and sometimes in the left. So she was prescribed some small tablets for her knee pain. We think it was steroids, and she told that it was her ptosis felt a little better on and off. So we know that, with this classical presentation, it could be a myasthenia gravis. So it is an autoimmune disorder wherein there is antibodies against the nicotinic receptors, acetylcholine receptors at the neuromuscular junction. So there could be weakness and fatigability of the skeletal muscles. And remember, most of these patients with just ocular myasthenia go on to develop general myasthenia, and they are worsened for some of the drugs. So that is important to know. So looking at the clinical manifestation, there is the hallmark would be the two Fs, the fluctuation and the fatigability. So you can see this patient with sustained upgaze, and on exertion, he's having this drooping of the eyelid of the right eye. And then there is enhancement of the ptosis. So on lifting the right eye, there'll be the ptotic eye becomes more ptotic. So that is the enhancement of the ptosis due to Hering's law. And then there is a Kogan twitch sign wherein when the patient looks from downgaze to upgaze, there is a twitching of the eyelid. So all these may not be there in every patient. It's very not easy to elicit all of them, but we can definitely pick them up in some patients especially before they start treatment. So remember, there is no pain, there is no pupillary abnormalities with this patient, with these myasthenia patients. And if the patient goes on to develop general myasthenia, important to rule out all the systemic associations like difficulty in swallowing, breathing. And this lady, if you can see her, she has weakness of the orbicularis oris. She's got a myasthenia sneer. And peekaboo sign is when there is weakness of the orbicularis oculi muscle, wherein you ask the patient to close the eye, but it will not be sustained. It just gapes up a little bit. So looking at the diagnosis, so clinically, very easy test to be done in your clinic will be a ISPAC test, which is 90% specific. Remember, you can only test ptosis with this. You cannot be testing extraocular muscle pathology with this because you want the temperature to kind of seep in. So the acetylcholine esterase enzyme is destroyed by the decreased temperatures. So that did not happen with the extraocular muscles. Then pharmacologically, you can do the neostigmine. Hydrophonium is not done anymore. Now, after that, serological is almost 100% specific, especially the anti-AChR antibodies, especially the binding ones. Now, if this is negative, you can also do the anti-MuSK and anti-LRP. Remember, 10 to 20% of these patients are seronegative as well. So then we have the electrophysiological, wherein you have single fiber EMG, where the more number of nerves, the muscles you test, the more sensitive it becomes. Also, we have the repetitive nerve stimulation test, wherein you test the first stimuli and the fifth one and then compare both of them. So if there is a decremental response, then again that is positive. And all these patients need to undergo a CT scan to rule out thymomas because they are having some kind of pathology in these myasthenia patients. And once you remove the thymus, also the symptoms of myasthenia improves. So also remember to do anti-immune profile. And so diagnostic valuation, typical history examination findings. in positive test on ISPAC or tensinon test, then you do the titers for the antibodies. Now, if the titers are positive as such, then you don't have to go with any other test. You can directly start on your treatment. But if that is negative, or you have a seronegative myasthenia gravis, then you'll have to do the electrophysiological test. So symptomatic treatment, we can give Frenil, lubricants, crutch classes, and eye patch. First line of treatment is pyridoxine, but however it works in very mild cases. And the main role would be for the steroids. So it reduces the progression to the general myasthenia gravis. And if they don't respond, then again we'll have to, or they don't tolerate prednisolone, we'll have to put them on azathioprine, cyclosporin, or any immunomodulators. So plasmapheresis and IVG more in case of ocular myasthenia, not in case of general myasthenia, no role much with ocular myasthenia patients. And newer drugs like eculizumab and ravulizumab are used in refractory disease. So this is our second patient, 65-year-old with drooping of eyelids, no other complaints, no diurnal variation. So he started noticing these symptoms 15 years back, slowly progresses. The family members could also not pick it up that early. He came on very late, and this was picked up with the previous photographs that we could see. So yeah, so these are the clinical points pointing towards a patient with CPO. It could be progressive, bilaterality. There is no remission like you see in myasthenia, and no response to cholinergic drugs. Ptosis is an early manifestation, and later on they can have ophthalmoplegia, usually bilateral. Downward gaze is preserved till late. So you have isolated ocular myasthenia, isolated ocular findings in CPO, and with plus you have both the systemic issues with the ocular findings. So remember to always check the previous photographs and ask for the family history. So this is another girl with the same CPO kind of scenario, but she was very young. So usually CPO comes in the middle age and old age group. But then this lady, this girl who is 11-year-old, and she had retinal issues. And so this is again a KSOS syndrome, wherein they have additional symptoms like cardiac conduction defects. And so diagnosis for CPO, you'll have to ask for the family history genetic test, and muscle biopsy is what is confirmatory. And these show a few red rag fibers with sarcolemmal attenuation. So treatment again, symptomatic treatment, ptosis undercorrection because there will be poor bells, strabismus once the deviations are stable, and coenzyme Q, just like it works in any mitochondrial disorders, have shown good promising results. It does not change the course, but it definitely improves the symptoms. So scleral contact lenses have been tried in these patients, especially if these patients are having ocular surface disorders. So this is a third case. So she's a 55-year-old with bilateral proptosis, conjunctival congestion, and dystopia. So it's a no-brainer. The moment you look at her, we know it is thyroid, but thyroid may not present just like this. It's important to know that they can have just this most common and one simple sign, that is eyelid retraction. So Graves' hyperthyroidism is most commonly associated with thyroid disorder, but it can also happen with Hashimoto thyroid eye disease, especially in the hypothyroid phase, and any age after adolescence is very common. So this is a lady where you can see she's having lid retraction. But what you can see is also that her T3, T4, and TSH is normal. So but beyond that, you will always have to do thyroid antibodies, because she was in her euthyroid state, and that's why the thyroid results are normal. So, but you'll have to do the antibody test, like the TPO and the TRAB antibodies. So important to remember in these patients is to keep them euthyroid, and selenium can be used in mild cases. Lubricants and lifestyle modification, avoid smoking, and avoid fluctuations in the thyroid hormones, and monitor for progression, because she's going to develop Hashimoto thyroiditis and become hypothyroid eventually if not monitored. So they can also present with the external ophthalmopathy, like this patient who's a typical case with 50-year-old. So he's having decreased in elevation and abduction, but this other lady has hypertropia and decrease in depression. So again, check the patient with thyroid disorders, anti-TPO, anti-thyroglobulin, and if it is positive, then you'll have to start on treatment. So again, shows enlargement of the muscle bellies with the relative sparing of the anterior tendons. This is very, very important to know, and look for activity. Also rule out compressive optic neuropathy. Now very important is to rule out dysthyroid optic neuropathy. So very important thing to remember here is there is activity, there is severity, and there can be a disconnect between the two. So just because the eye is red, you have to treat, and because the eye is not red, you don't have to treat, is not the dictum. They can have a moderate severe patient where something deep is happening, but the eye may be white. So that is very important to know. So always do a CT scan and an MRI to see these defects. So orbital decompression surgery is needed for these patients, and strabismus surgery once they're inactive. So teprotumab is important, a new drug, improves proptosis, and it's become a part of the UGOGO treatment guidelines, and selenium can be used in mild cases. I think I'll stop here. This is about the orbital myositis. Here, both the enlargement of muscle bellies with the tendons is noted. And of course, the congenital fibrosis of extraocular muscles, we'll get to know with the photographs and the lid changes. So what you can see is ptosis and diplopia is there in all of these patients, but with these subtle things that we can pick up each one of them. Thank you.
Thank you, Dr. Monisha. Now I would like to invite Dr. Remya Edicheri to talk about the droopy eye mystery, decoding third nerve palsy.
Good morning. So I just want all of you to have a look at these three pictures and the extraocular movements. All of them have ptosis, and just have a look at the extraocular movements. I hope all of you agree if I tell these are cases of third nerve palsy. So why do we go further? Yes, we need to know the cause of third nerve palsy, where it is, localization, and to decide about the management. So typically it starts from history, whether the diplopia is binocular and it is usually vertical, drooping of the eyelid, periorbital pain, headache, nausea and vomiting to rule out any intracranial space occupying lesions, other neurological features like confusion, vertigo, weakness of limbs, involuntary movements of hands and altered sensorium. You have to ask for ischemic risk factors like diabetes and hypertension, any history of trauma. The patient might have forgotten, it may be just a trivial trauma, but later on the patient presents with a third nerve palsy, history of tumors and any history of anti-tuberculous treatment. Coming to examination, look for the head posture, any face turn, head tilt or chin up position so that the patient gets a binocular vision, ocular posture, Hirschberg test, extraocular movements, all the versions as well as the deductions. So we are aware that this third nerve supplies this LPS muscle, so it causes ptosis. And superior rectus, so that is why there is defective elevation, medial rectus adduction, and inferior rectus defective depression. So you have to also examine higher mental functions, other cranial nerve involvement, anterior segment evaluation especially for pupil, posterior segment evaluation for papilledema and optic atrophy. Coming to the pupils, we know that the vasa nervorum that supplies the main trunk of the muscle nerve is courses in the center of the nerve. So you won't get usually pupil involvement in a ischemic third nerve palsy, whereas in compressive third nerve palsy, the pupilomotor fibers are involved, so you'll get a pupil involving third nerve palsy. But even in diabetes, in 1/4 of the cases, you can have a pupil involvement. You should remember that. So this is the aneurysm causing a third nerve palsy, that is pupil involving, whereas diabetes without pupil involvement. And you can do a diplopia charting that will give you a crossed diplopia with the involved eye image in the upper. And Hess charting to know the progression of third nerve palsy. Here the right side the chart is smaller, so the right is the affected eye, medial rectus, superior rectus, all involvement is there. So, but the lateral rectus is normal, so it's a right side third nerve palsy. So when you have a third nerve palsy, you should know what is the clinical diagnosis, what is the anatomical localization, and what is the etiology. So clinical means whether it is isolated or other cranial nerves are involved, whether it is complete or partial, and pupil involved or spared. Coming to localization, it can be from the nuclear level to the orbital apex. I will go one by one. So in the nucleus, third nerve nucleus is a complex which is situated at the midbrain at the level of the superior colliculus. So you have a central caudate nucleus which supplies both the sides, both the LPS. So you will get either bilateral ptosis or no ptosis, depending upon whether the central caudate nucleus is involved or not. And the superior rectus muscle is supplied by the contralateral nucleus. So if you have a nuclear involvement, you can get a weakness of elevation in the other eye. And isolated unilateral third nerve palsy is never nuclear in origin. And this is something called the Daroff's rule, where it tells whether it is an obligate or exclude a nuclear lesion. If you have a bilateral third nerve palsy without ptosis, or unilateral third nerve palsy with a contralateral SR weakness and bilateral partial ptosis, it should be a third nerve nuclear involvement. Whereas the conditions that exclude include unilateral ptosis, unilateral internal ophthalmoplegia, unilateral external ophthalmoplegia with normal contralateral superior rectus function. So coming to the fascicular level, here you can see the nucleus, the nerve traverses through the red nucleus. It is in close association with the red nucleus, substantia nigra and cerebral peduncle. So depending upon the involvement, you can have different syndromes. So if you have an ipsilateral third nerve with a hemiparesis, that cerebral peduncle is involved. If you have red nucleus involved, you will get a contralateral tremor and hemianesthesia with a third nerve palsy, ipsilateral third nerve palsy. And you have both, then it is cloud syndrome. And if it is ipsilateral ataxia with ipsilateral oculomotor nerve palsy, this is North-Nagel syndrome. So coming to the fascicular part, then you have the basilar part where the usually gets the isolated third nerve palsy. So here the nerve runs between the posterior cerebral artery and superior cerebellar artery in parallel with the posterior communicating artery. So a posterior communicating artery aneurysm can cause an isolated pupil involving third nerve palsy because it is compresses the pupillomotor fibers. So this is, so in a case of acute isolated third nerve palsy involving pupil, you should order for a MR angiography or CT angiography to rule out a posterior communicating artery aneurysm. So coming to the cavernous level, the third nerve lies on the lateral wall of the cavernous sinus with along with other cranial nerves. So you can have a third nerve palsy with or without involvement of the other cranial nerves. And if the sympathetic fibers are involved, you will get a small pupil with a third nerve palsy. Coming to the superior orbital fissure, all of you are familiar with this diagram. We are drawing it from our MBBS days. So here the third nerve divides into the superior and inferior branch. So you can have a branch third nerve involvement, like either superior or inferior, along with other cranial nerves. And if there is a second nerve, the orbital apex involvement, it can affect the vision and also cause proptosis. So where will you get a multiple cranial nerve palsy? In a meningeal involvement, as in some types of infections like tuberculosis, inflammatory and neoplastic lesions, or a perinuclear spread from a skin cancer, systemic associations like botulism, wernicke's encephalopathy, all these cases you can have a multiple cranial nerve palsy. Then etiology wise, whether it is vascular, traumatic, like in a CCF, then compressive lesions, history of ATT and CCF also should be ruled out. So just a word about aberrant regeneration. It usually happens in traumatic, compressive and congenital lesions. It is due to disruption of the axons and it never happens in ischemic palsy. So just see this case. So here you can see when I cover the left eye and when he is adducting, his palpebral aperture widens. That means it's a inverse Duane's sign. Then you can have a pseudo von Graffi sign where the lid retraction occurs when the patient looks down and the pupil constricts on adduction, that is pseudo Argyll-Robertson sign. So how will you go about in a case of third nerve dysfunction? So if you have an isolated third nerve dysfunction, if the age is more than 50, I evaluate the pupil. If the pupil is sparing, complete third nerve palsy, then you can just evaluate for all the ischemic factors. Myasthenia gravis always should be in consideration. Myasthenia never involves pupil. And but if it is not improving, and if it is a partial third nerve palsy, better to get an MRI, neurological imaging done. And if you have a less than 15-year-old, always do a imaging. And in a non-isolated third nerve palsy like brainstem signs or a meningeal involvement, other cranial nerve palsy, always get an MRI with MRI always. So this is the case when you do an imaging, age less than 50, multiple cranial nerve, recurrent neuropathy, evidence of raised ICP, aberrant regeneration and no signs of improvement, pupil involvement or partial palsy. So just a few cases. 68-year-old male, diabetic and hypertensive. This is the patient, left complete ptosis. You can see adduction, elevation and depression is affected. Pupil was normal. So this is clinical diagnosis would be isolated left complete pupil sparing third nerve palsy. Here the most probably it would be ischemic. Coming to the second case, it's a 48-year-old male. He had a history of RDA long back. He complains of double vision. So you can see the right, there is a ptosis. Right adduction is affected, elevation is affected. Also, abduction is also affected. So it's not an isolated palsy, it's a multiple cranial nerve palsy. Third, sixth is involved. And now you have to look for a fourth involvement. So how will you look for the fourth nerve involvement in a case of, sorry, it's not working. Huh? Fourth nerve involvement, I think the video is not playing. Okay. So you ask the patient to look down. So you will follow the nasal or superior limbal vessels and look for the intorsion of the eye. Okay. So the last one, 11-year-old boy, bilateral drooping and double vision. So he presented like this. So there is bilateral ptosis. Here the only movement was both eyes abduction was present, but all the other adduction, elevation, depression all were affected. So this is a case of bilateral third nerve palsy. This should be nuclear level. So this is a case of temporal lobe glioma which has infiltrated into the midbrain. This is a 76-year-old female, hypertensive, acute onset severe headache, drooping of the left eyelid. So here left complete ptosis. See the pupil. So this is left pupil is dilated. So this is a left eye isolated complete pupil involving third nerve palsy. So here you should order for a CT or MR angiography. So take home message is assess the pupil, lid and extraocular movement. They are like a triad. If you have a pupil involvement, always look for lid and extraocular movements. If you have Horner's small ptosis, you should always rule out Horner's syndrome. So you should look for all this. Take a proper history that will guide you in the diagnosis. Always look for other cranial nerve involvement. And all patients with a new onset third nerve palsy require CT or MR angiography to rule out an intracranial aneurysm, especially PCIOM. Thank you.
Thank you, Dr. Ramya. I would now like to invite Dr. Neena to talk about disorders beyond the nucleus, basically supranuclear and internuclear disorders.
Thank you, Ramya and KSOS, for this opportunity. So my talk is on beyond nuclei. So as ophthalmologists, we are all familiar with the monocular ocular movements and binocular ocular movements. But how many of us know that there is a triple level of control of eye movements, starting with the supranuclear level, which is the cortex, the basal ganglia, the superior colliculus, thalamus and cerebellum, coming to the nuclei and internuclear pathways, which are located in the brainstem, where the nuclei of the third, fourth and the sixth cranial nerves are there. And finally, the infranuclear pathway. So the triple level of ocular motility control is very important to understand because there is a lot of things happening at the cortical level, at the nuclear level, infranuclear and internuclear levels. So the cortical centers, they control when and where eyes should move, whereas the brainstem centers, that is the horizontal gaze center and the vertical gaze center, tell you how your eyes should move. So remember this and you will be able to figure out the eye movement disorders. This is important because in a multi-speciality hospital, we might be called upon to look upon certain ocular abnormalities. And if you really don't know this, we'll be stuck. So based on this, you can classify ocular movements into fast ocular movements and slow ocular movements, and into gaze shifting and gaze holding eye movements. Like gaze shifting would be smooth pursuits and smooth saccades and vergences, whereas gaze holding is more of the reflexes, the vestibulo-ocular reflex and optokinetic reflex, which help to focus an object of interest into your fovea. So let's talk about the horizontal and vertical gazes. Now, very important that you understand a bit of anatomy here, because without understanding this, you cannot understand the abnormalities. So remember that you have separate gaze centers for horizontal and vertical gazes, and remember that the command for the gazes comes from the brain. So the contralateral frontal eye field gives you command to look to the opposite side. Suppose I want to initiate a saccade to my right. It's my left frontal eye field which gives that command. That is a fast eye movement. Whereas the pursuits are usually controlled by the same-sided posterior parietal cortex. That is, the ipsilateral pursuits are controlled by the parieto-occipital cortex. So remember, contralateral frontal eye field controls saccades to my opposite side, and ipsilateral posterior parietal cortex controls pursuits to the same side. So remember, horizontal gaze center lies in pons, in pontine tegmentum. So you have the common final pathway we all have been studying from MBBS days, PPR of paramedian pontine reticular formation, and the nucleus of the third and sixth cranial nerves. Finally, it happens. I'll show you with videos how it happens. So let's look at horizontal saccades, because as ophthalmologists, we check for ductions, versions, we forget vergences, we forget saccades, pursuits. If you are going to write a higher exam, these are very important. And in a neurophthalmic setup, you should know how to test for saccades. So, I'm sorry. So I hope the video plays. Yeah. So this gentleman is shifting his gaze rapidly between two objects which are held across his horizontal gaze eye field, and these are horizontal saccades, fast eye movements which help you to shift your gaze from object of interest. So how does this happen? Suppose I want to look to my right, my left frontal eye field gives a command, and then impulses come down to the contralateral PPRF and sixth nerve nucleus. So remember, sixth nerve nucleus has connections to the same-sided lateral rectus, and it talks to the opposite third nerve via the tract known as medial longitudinal fasciculus. So what happens? The PPRF tells the lateral rectus of the same side to abduct and tells the contralateral medial rectus to adduct. So a conjugate movement happens to the right. So this is what happens when you have a horizontal gaze. This is the pathway for horizontal saccades. Now coming to pursuits. Remember, P for P, parieto-occipital cortex controls your pursuit. So it's the ipsilateral posterior parietal cortex which controls pursuits. So this is a tracking movement across the horizontal visual field. So again, the pathway is the same, PPRF sixth nerve nucleus via MLF to the contralateral third nerve nucleus, and a conjugate movement is made. Now let's move on to vertical gaze centers. The vertical gaze center is in the midbrain at the junction of thalamo-mesencephalic junction, and two nuclei are there. If you don't want to remember, you can forget the rostral interstitial nucleus of MLF and nucleus of Cajal. So again, it is mediated through cranial nerves 3 and 4, so which initiate the vertical eye movements. So the vertical gaze center is in midbrain, and you can look at this picture. This gentleman is looking at two objects held across his vertical eye field, and these are vertical saccades. So both frontal eye field has to fire if you have to initiate a vertical saccade, because I said it's contralateral, right? Saccades are initiated by contralateral frontal eye field, but it comes down to the MLF in the midbrain, and then through the third and fourth nerve. Moving to the pursuits, you know it's P for P, posterior parietal cortex for pursuits. Again, it has to be bilateral. And there's a little bit of, complexity here. You have torsional activities. So if you don't want to remember, just forget it. Vergences are also important because they allow you to fixate an object bifoveally. So accommodative vergence happens when there is a retinal blur, and fusional vergence happens when there is an image location disparity. There are vergences areas in the occipital cortex, in the midbrain, and the pons. So finally, the action happens with the third nerve and sixth nerve, which act on the medial rectus and lateral rectus, reciprocally activating and inhibiting those muscles which are involved in convergence and divergence. A word about vestibulo-ocular reflex. These are kind of peripheral controls of horizontal and vertical gazes. What is this simple? Just remember that when you rotate your head to one side, eyes will dramatically, naturally move to the opposite side. This is a basic reflex. How does that happen? Suppose I rotate my head to the left. My left horizontal semicircular canal is stimulated, vestibular nucleus is stimulated. It has connections to the contralateral abducens nucleus and to the same side MLF. And again, by the same pathway, there is a conjugate movement happening to the opposite side. So this is what is happening. And it helps to hold the head steady during brief head rotations. So you all know about cows and cup and all. I'm not going into this. Optokinetic reflex. What does this do? It allows us to follow an object in motion while the head remains stationary. So it's a combination of saccades and pursuits, but here you need an intact visual pathway. Is it 8 minutes or 10 minutes? Okay, now cerebellum is a master modulator. It is also important in your eye movements because it fine-tunes all your eye movements. And if you have a problem with cerebellum, you get problems in your saccades, like you overshoot hypermetric saccades, and it has connections to all the important centers. So coming to the supranuclear disorders in a nutshell, you can have gaze palsies, gaze deviations, saccadic disorders, pursuit disorders, vergences, skews, nystagmus, ocular oscillations. I won't be going into all, but a few. So what is conjugate gaze palsy? Let's start with first the cortical disorders affecting the gaze. So gaze can be affected in problems in the cortex. Why? Because your frontal eye field and frontal eye field is responsible for your horizontal gaze, isn't it? So suppose you have look at this video. This lady is having a seizure and she has a gaze deviation to the left because there is an irritative lesion in her right frontal lobe. So the frontal lobe is firing, and so she has contralateral gaze deviation. As opposed to this lady who has a paralytic lesion of her left, of her right frontal lobe, she is unable to look to the opposite side. So her horizontal gaze is paralyzed. So the eyes will deviate to the same side of the lesion. So your irritative lesions will make you look away from the lesion, whereas a paralytic lesion will make you towards the lesion. Now also, it will also help you to localize the lesion. Imagine you have a patient with homonymous hemianopia. You don't know, is the lesion in the parietal cortex or in the, is it an occipital lobe lesion? How do you test? If the ipsilateral pursuits are spared, that means it is more likely to be an occipital lobe lesion than a parietal lobe lesion. That is how you can localize. Coming to conjugate gaze palsy. Now, this is very similar to a 6-nerve palsy, but the lesion is either in the PPRF or 6-nerve nucleus. The difference is that not only you get an abduction defect, you get a contralateral adduction defect. The whole gaze to one side is gone, horizontal gaze. That is how you differentiate it from a pure fascicular 6-nerve palsy. INO, we all know, is due to a lesion in the medial longitudinal fasciculus. So what happens? On the side of INO, you have adduction defect, and the contralateral side, you have abducting nystagmus. Because what happens here is that the 6th nerve is trying to talk to the 3rd nerve, move the eye, but MLF is not working. So I cannot adduct, but 6th nerve, the PPRF is telling the 6th nerve, move the eye to one side. So 6th nerve is acting, but 3rd nerve is not acting because the MLF is not giving the information. So this is a wall-eyed binocular internuclear ophthalmoplegia. You can see the patient is not able to adduct eyes in both eyes, but is able to abduct with that abducting nystagmus. Convergence could be spared sometimes if it's a posterior INO. You also have other features like, pursuits. And can I take just 1 minute? Yeah. So if it's a young patient, think about multiple sclerosis. If it's an older patient, think about a CVA, a stroke. 1.5 syndrome is when you have a lesion in the PPRF and MLF together. Only movement would be the abduction. Coming to vertical gaze palsy, let's start with Parinaud's. Ramya already told you about the arrangement of the 3rd nerve nucleus. Now, in Parinaud's syndrome, there is a loss of inhibitory control of the 3rd nerve nuclei in the midbrain, in the rostral midbrain at the pretectal level. So they fire, all of them fire together. So there is a loss of inhibition. They fire together, and that's the reason why you get the convergence retraction. It's not a nystagmus, it's an abnormal convergence retraction movement, an upgaze palsy, pupillary light near dissociation, Collier's lid retraction, etc. This girl has the typical sunset sign with the upgaze palsy with eyes placed in the down gaze because of a pinealoma compressing the midbrain tectum. Progressive supranuclear palsy is also another condition which will present with vertical gaze palsy. It's very similar to Parkinson's disease, but an aggressive form. But how do you differentiate? In Parkinson's, the vertical gazes are usually spared. Horizontal eye movements become slow. But in PSP, what happens is the vertical gazes are the ones to go first, the up gaze and then slowly down gaze. And patient has a lot of difficulty because of this condition. Typical MRI picture is the hummingbird and the Mickey Mouse sign due to the tegmental atrophy with the preservation of tectum. Parkinson's patients can have convergence insufficiency. So let's go to this last slide. How do you differentiate a supranuclear lesion from an infranuclear lesion? Look for the presence of vestibulo-ocular reflex. So if the doll's eye maneuver or the vestibulo-ocular reflex is intact, you can be sure it's a supranuclear lesion. So that's how you identify this. And this is the last video. This child has a very interesting eye movement disorder. Can anybody help me with this? So look how and I'm giving him a toy and I'm asking him to look at another toy. See what he does. See, instead of making a voluntary saccade, he used a head thrust. He did like this. I gave him a toy and I gave him another toy. Instead of looking at like this, he did like this to shift his gaze from one toy to another toy. So this is because he's unable to initiate voluntary saccades, but he can initiate it with vestibulo-ocular reflex or a Doll's-eye maneuver. This is a classic case of oculomotor apraxia, which is seen in Joubert's. This case was Joubert's with the classic molar tooth signs. So finally, to say that, remember that frontal eye field controls contralateral saccades. Posterior parietal cortex controls ipsilateral pursuits. Horizontal gaze center is in the pons. Vertical gaze center is in the midbrain. Your vestibular apparatus controls slow eye movements to the opposite side. Supranuclear lesions are usually bilateral, do not usually produce diplopia, and a vestibulo-ocular reflex is preserved in supranuclear palsies. So I hope you were able to understand a bit of it.
Thank you, ma'am. That was a wonderful talk on supranuclear. Very difficult to understand, but you have explained it very nicely with videos and pictures. So next we have Dr. Sumita Muthu. She is a senior consultant at Narayan Nethralaya, Bangalore. She will be talking on tilts and turns, understanding 4th and 6th nerve palsies.
Thank you. So before I begin, I just want to show off hands on how many postgraduates we have here. No? Anybody? Okay. So we will skip the basic level of examination and workup and probably go to straight away to more of case examples. But of course, no talk on neuro-ophthalmology is complete without neuroanatomy, as Dr. Neena said, and we definitely have to spend some time on the neuroanatomy. So to talk about the 4th nerve palsy, we have to know where the 4th nerve nucleus is located. It's located at the midbrain, and you can see how it is the only nerve which exits at the dorsal side. So this makes it particularly vulnerable to trivial trauma. So following just a head bang, following just some trivial injury like maybe being punched on the face, people come up with 4th nerve palsies. So the 4th nerve can be divided into the following parts: a fascicular part, a precavernous part, an intracavernous part, and an intraorbital part, because the pathologies that involve all these parts are different. So classical presentation of a person who presents with 4th nerve palsy is with vertical diplopia. They often have a head tilt to the opposite side. They complain of tilting of images, and of course asthenopia because of all of these symptoms, because it particularly affects the down gaze. There is difficulty in getting down the stairs, there is difficulty in reading, and most of the symptoms are exaggerated during these activities. The causes, of course, most common one is congenital, but they can present much later in life when they get decompensated. Okay, the other most important cause, as I said, is trauma because of the vulnerability. Then it can be idiopathic and neurological causes, which includes both vascular as well as tumor. These are the various list of causes of acquired palsy. But what you must know is when there is a bilateral superior oblique palsy, this can be seen in cases of trauma, severe trauma. So as I said previously, it's very important to differentiate an acquired superior oblique palsy with a decompensated congenital superior oblique palsy. How do you do that? One thing is the patient complains of intermittent diplopia and can fuse. The amount of deviation that you usually measure is very large, and still sometimes the patient fuses. This suggests that they have good vertical fusional amplitudes. Okay, so you may measure about 14 to 20 prism diopter, but the patient is still ortho sometimes. This itself tells you that it's a decompensated congenital nerve palsy. Other most important signs being spread of cometons, and you can also look for the old photographs where the patient particularly maintains a head tilt. One common thing that I usually ask the patients is that when you take photographs for, say, passport or something, does the photographer often tell you to correct your head tilt? This is something that they would testify to, saying, yes, they've always told me to keep my head straight. So this again picks up a subtle congenital 4th nerve palsy. With respect to history, look for history of trauma, look for history of diabetes, hypertension. These are all again important histories because you have to rule out the differential diagnosis for a 4th nerve palsy. These are all various diseases that can also involve a vertical muscle. For example, a thyroid disorder involving an inferior rectus may give a false impression of a superior oblique nerve palsy. So again, examination, do the usual tests. I think we are going to skip the basic test. In a case of mild paresis, you'll only find a mild inferior oblique overaction, and in case of moderate and severe, you'll find more severe inferior oblique overactions. So because usually the SO underaction as such is very subtle and often difficult to pick up on examination. And the Gold's rule you all know, a right hypertropia which increases on the opposite gaze, that is the left gaze, and worsening on the same side head tilt is almost always suggestive of a superior oblique palsy, because that is the most common vertical muscle to be involved in any nerve paresis. So again, bilateral nerve palsy can be diagnosed by a simple test called Maddox rod test, wherein if it is bilateral, the amount of torsion will be more than 10 degree. So these are all differences between a unilateral and bilateral superior oblique palsy. Usually they present with V pattern esotropia, and what you also see is that on either side, so on right head tilt there will be a right hypertropia, and on left head tilt there will be a left hypertropia which is increasing. So this is how you recognize a bilateral superior oblique palsy. The typical diplopia charting, this is what it looks like. It's worse in the direction of action of the superior oblique, okay, that is in the opposite depression, and this is how the Hess charting looks like. Okay, I think we will not go into details of that. So let us move on to sixth nerve paresis. Sixth nerve nucleus again is located at the mid-level of pons. It's ventral to the floor of the fourth ventricle. And what's important is the fasciculus of the seventh nerve curves around it. So this makes the association of the nucleus and the fasciculus of the seventh nerve very close, and therefore lot of lesions that affect the nuclear level of sixth nerve coexist with that of the seventh nerve. So this is where the nucleus is located, and you can see the fasciculus of the seventh nerve winding around it. Okay. So again, 60% of the fibers, I think Dr. Nina already explained how the fibers distribute. They distribute to the same lateral rectus, whereas 40% of the fibers go to the opposite third nerve nucleus through the MLF and the PPRF. So therefore, when there is a PPRF lesion, she already explained, there is an ipsilateral gaze palsy. So when the facial colliculus is affected, you see again seventh nerve palsy along with the sixth nerve palsy. So these are the various syndromes that are associated with the fascicular lesions. So here you can see the sixth, seventh and the pyramidal tract gets affected. That's called the Millard-Gubler syndrome. And Raymond syndrome is nothing but the sixth and the pyramidal tract getting affected. The Foville syndrome involves all of these nerves and the PPRF. So fifth, sixth and seventh along with PPRF. So it can also present with a Horner syndrome kind of picture because of the sympathetic involvement. So this is the basilar part. So what's most important structure you can see here is the petroclinoid ligament. The nerve passes under the petroclinoid ligament, very close to that, and therefore is very susceptible to increased intracranial pressure or to increased intracranial tension. So that's when it gets compressed and it becomes that's why we call it as a non-localizing kind of sign. So even in the presence of tumor anywhere else within the cranial cavity, you can see that because of increased intracranial tension, there's always a sixth nerve palsy. So subarachnoid lesions like meningitis, epiangle tumors, subarachnoid hemorrhage, all of this can also cause a sixth nerve palsy. Intracavernous part, of course, you know that I'll just show you in the next diagram. You can see that it's closely associated with the internal carotid artery. It's on the lateral wall over there, and it can be affected by various keratoco-cavernous lesions like this. The Tolliver-Hunt syndrome, tumors, fistulas and aneurysms. So here you can see there is an abduction deficit, and what you can see is a intracavernous carotid aneurysm. So this is the aneurysm that you can see over here. There is also an mild ptosis and meiosis. As I previously said, the sympathetic fibers can get affected, because of which a Horner syndrome kind of picture can be present. So this is the intraorbital part. You can see that the nerve exits at the apex of the orbit and then supplies the inner orbital surface of the muscle. So there can be various lesions that can affect the intraorbital part. For example, cysticercosis lesion can affect this intraorbital part. So this is the various classification of the nuclear, fascicular, subarachnoid, intracavernous and intraorbital part, and various etiologies that can affect each of these parts. So coming to the most common etiologies again is microvasculopathy associated with hypertension and diabetes. You also see certain undetermined causes. For example, a child presents with sudden sixth nerve palsy. You do a neuroimaging, you do all of the investigations, everything else is negative. Okay, then you just conclude that it's idiopathic. Most often they follow viral infections. They can follow an episode of fever, but there is no particular etiology. We also saw during the COVID times that certain sixth nerve palsies were associated with the vaccinations. After vaccines they presented to us, but then again we could not find the particular etiology. So again, depending on whether it's an adult or child, you can classify. So I'll just skip the etiologies and we'll just straight away move on to certain case examples. So the management, of course, you have to do the necessary investigations, do an imaging when it's absolutely necessary. So these are all the following situations where you definitely have to do a neuroimaging. That's when you see it in a young patient, when there is associated pain, when there's associated history, any neurological history, when they present with any other cancers to rule out metastasis, when it is bilateral, when there is papilledema. These are all situations where you definitely have to neuroimage. Again, when you're following up the patient and when there is progression and there is no resolution, that's again a situation where you have to neuroimage. Management, of course, in this interim period until it resolves or until that 6 months period where you can actually operate, you have to manage them with prisms or with occlusion. So botulinum toxin is again an interesting option. So here you can see that we have given the botulinum toxin to the left medial rectus, okay, and after 3 weeks you can see that there is some resolution of the horizontal deviation over here. So that can be a good option to resolve the diplopia and also to prevent contractures in the long run. So let us look at this case example. This gentleman presented with history of double vision for more than a month and reduced corneal sensation. That's an important point to be noted. Okay, so here you can see the Hess charting showing a typical limitation. So there was an extra axial mass on neuroimaging which we found which was indenting the left trigeminal nerve. Therefore, we had a sixth nerve along with reduced corneal sensation. So other cranial nerve examination becomes very, very important when it comes to any nerve palsy that you come across. So here you can see a very interesting case. A gentleman comes with the history of diplopia following trauma with football, and he presented to us. Most of the anterior and posterior segment examination was normal. On ocular motility, of course, we found a mild abduction limitation. So we did a neuroimaging and it was unremarkable at that point except for some non-specific arachnoid cysts that we found. So then we thought, okay, this is like an idiopathic sixth nerve palsy or a traumatic sixth nerve palsy which would probably resolve over time. But suddenly 3 months later he presented with sudden proptosis and chemosis. Okay, and again corneal sensation was reduced and there was further limitation of the abduction. Abduction was -4. And what we found on neuroimaging was that there was a CCF. So there was an indirect type of CCF. It was slowly building and suddenly it worsened and presented with all of those symptoms. Then when the patient underwent embolization, all of the symptoms resolved. And you can, of course, see the coiling being done over there. And this is post the procedure. You can see that the abduction is almost the same. There's a slight improvement, but all of the other signs have reduced. The proptosis, chemosis, and all of the other signs have reduced. So this patient awaits a squint surgery. So certain other causes, as I already mentioned, cysticercosis can also present with localized nerve palsies. Again, fundus examination is the most important thing when you come across a sixth nerve palsy to rule out any non-localizing signs. So this patient again had a left abduction limitation and improved with IV and oral steroids and immunomodulators. Any guess on what condition this patient had? Of course, it's a sixth nerve palsy, but he improved with oral steroids and immunomodulators. That helps you clinch the diagnosis. Can anybody guess? Myasthenia is a good guess. Of course, it can respond, but anything else? I will give you a clue. You have to look at the blood workup. So it was an IgG4 neuropathy. You can see how it involves the pachymeningeal inflammation you can see over here. Okay, so this was an IgG4 neuropathy. So the classical thing in IgG4 neuropathy that you see is dramatic improvement with steroids or with immunomodulators. Other thing is the increased IgG4 count, of course. And also, if you happen to do any biopsy for any of these lesions, not of course the meninges, when they present with orbitopathy, what you can see is the increased plasma cell infiltration. So to conclude, when it comes to any neurological signs in case of ophthalmology, we definitely need a keen eye to catch the associated signs and symptoms. Always obtain relevant history and investigations. Do not do the same set of investigations for all the patients. Of course, you are bound to pick up the most common things, but certain uncommon things, etiologies you may not pick up. And never say no to neuroimaging. Sometimes, for example, when you saw that gentleman, when it seemed obvious that it's a traumatic sixth nerve palsy, but further later worsened, and he came, with an aneurysm, with a fistula, we definitely had to do a relevant imaging to look for a CCF. Again, right referral and treatment at the right time can always treat the patient. Fourth nerve palsy.
Sumita, can you wind up? It's almost 10
Oh, sure. Sorry. So, in case of fourth nerve palsy, always learn to pick up a congenital cause. Thank you, Dr. Ramya, and thank you, the Drishti, for having me here.
Thank you so much, Sumita. So next we have the last talk of this IC, Dr. Rosemary Tommy. She is a senior consultant at Ahilya Eye Hospital, Patambi, and she'll be talking on from bells to brainstem, tracing the facial nerve.
Very good morning, everyone. At the outset, I would like to thank Ramya for having me here. Now, after all these heavy brainstorming sessions, mine is going to be a very basic session. Bells to brainstem, tracing the facial nerve. Now, I'll just be briefing you what to do when you see a facial nerve in your OPD. Now, this is a muscle that affects facial communication expression so much. And if you look at the umpteen number of celebrities that have taken to social media, how they have overcome their facial nerve palsy trauma, we see how it affects irrespective of gender, age, social strata. Facial nerve is always something every opthal subspecialty has to manage. So ultimately, what do we want to diagnose? We want it to be diagnosed as, if it is Bell's palsy, we are happy. No imaging, no treatment, most of the patients are going to improve. Now, you all know Bell's palsy is a total unilateral lower motor neuron lesion with a classical drooping eyebrow, drooping eyelid, flattening of nasolabial fold, drooping corner of the mouth. But to diagnose that it is only Bell's palsy and not to worry, we have to rule out all other causes of facial nerve palsy, and ultimately we need to know the neuroanatomy of it. So, how does the video work? Okay. So, I'll just brief you through. I'm sorry, PGs are not here. This is a facial nerve nucleus that is present in the lower part of the pons. You have the sixth nerve nucleus adjacent to it. Facial nerve fibers pass posteriorly and exit through the pontomedullary junction. Pontomedullary junction is a very busy place. You have the eighth nerve, everything, but I'm just explaining facial nerve. Facial nerve has a superior salivatory nucleus adjacent to it, which gives off lacrimatory and salivatory fibers. And the next component of facial nerve will be sensory fibers from the anterior 2/3 of the tongue. Sensory fibers, they get connected to the nucleus tractus solitarius. And there is a fourth component of facial nerve, general somatic afferent from the external ear, which also project to the spinal nucleus of trigeminal nerve. All pain, touch, temperature, everything is connected with trigeminal nerve. So facial nerve, 4 components: motor nucleus proper, then you have superior salivatory parasympathetic fibers, sensory fibers, we have the taste and external ear sensations. Now, classically they say there are 2 roots. You have a motor root, you have a sensory root. Sensory root, they call it the nervus intermedius, but when we look at the nervus intermedius, all those 3 roots, what we need to understand is there is a parasympathetic fiber within that sensory root. Okay, so this is what we have just seen. Now we'll go to the proper course of the facial nerve. Now, from the pons, okay, I'll go to the next slide. Okay, so from the pons, all fibers go into, I think the video is not working, all the fibers go into the internal auditory meatus and till genu here, till the genu here, they all pass together. And from the genu here, the story starts changing. So first we'll be describing the facial nerve proper. Facial nerve branchiomotor fibers, those go inside the facial canal. Midway, it gives off the nerve to the stapedius. Now this is very important because when you have a loud noise, it controls the movement of the stapes so that the noise is dampened. So what will happen in facial nerve palsy at this juncture? When the nerve to stapedius is impaired, a loud noise is going to cause hyperacusis to the patient. So that is the first branch of facial nerve. Then it goes downwards, exits out of the stylomastoid foramen, gives off a posterior auricular branch, then two branches, nerve to digastric and nerve to posterior highlight, and then it enters the parotid gland and gives off the classical, temporal, zygomatic, buccal, marginal mandibular, cervical branches, which we all know. So that will be the motor route of facial nerve. Next, we have covered the motor route. So next we'll see, okay. So to explain the next, we know that I'll just explain the exits. In this diagram, this will be the foramen ovale, foramen lacerum, foramen rotundum, and I've marked the pterygopalatine fossa there. Now I'm going to explain what is going to happen to the lacrimatory fibers. We have seen motor route, now we are going to see the parasympathetic fibers. Lacrimatory fibers from the pons have to reach the lacrimal gland in the orbit there. So all fibers, they pass together in the internal auditory meatus till the geniculate ganglion. So lacrimatory fibers pass into the geniculate ganglion, and from the geniculate ganglion, again I think the video is not playing. It's not working. Okay, now it's coming. Okay, so the lacrimatory fibers, they reach from the genu, and from the genu, these lacrimatory fibers move into the middle cranial fossa, and from the middle cranial fossa, they pass into the foramen lacerum, and from the foramen lacerum, they meet a friend there, the internal carotid artery with the sympathetic plexus there. Sympathetic plexus give off a sympathetic nerve, and these two pass together. Now for some names, those lacrimatory fibers are known as the greater petrosal nerve, while the sympathetic fibers from internal carotid is the deeper petrosal nerve, and together when they pass, they are known as the Vidian nerve. Now this Vidian nerve synapses in the pterygopalatine ganglion. Now to understand what happens further, we need to update ourselves with the trigeminal ganglion that is present there. Trigeminal ganglion, we all know, gives three branches. Ophthalmic, maxillary, mandibular. Ophthalmic branch, we all know, it enters the superior orbital fissure, gives up the nasociliary, frontal, lacrimal branches. Lacrimal branches supplies the lacrimal gland, that we all know. Then, the maxillary branch goes into the pterygopalatine fossa, gives out the zygomatic branch. Now what happens? The postganglionic fibers from the pterygopalatine ganglion jumps to the zygomatic nerve, jumps to the lacrimal nerve, and innervates the lacrimal gland. So that is the pathway of lacrimatory fibers. So now we have seen motor route, we have seen parasympathetic lacrimatory route. Now for the next one. Okay, now we are seeing the salivatory fibers. Salivatory fibers again, okay, this is again repeat. Okay, now for the next, okay, so we have seen the ophthalmic, we have seen the maxillary, and for the mandibular branch comes down, it gives us the lingual nerve. Lingual nerve is responsible for touch pain temperature, anterior 2/3 of the tongue. Now we are going to see the salivatory fibers that have to reach the submandibular sublingual glands. Okay, so the salivatory fibers, again, they pass through internal auditory meatus till they reach the genu. They pass along with the fibers of the facial nerve proper motor fibers. Halfway through, they realize they have to reach the submandibular gland. So from there, they jump into the middle ear cavity, exit through the petrotympanic fissure, and go along with the lingual nerve. And here on the path, they synapse with the submandibular ganglion. And postganglionic fibers from the submandibular ganglion innervate the submandibular and sublingual glands. So that is a salivatory pathway. So we are done with motor route, we are done with the parasympathetic fibers. So next we need to understand the sensory fibers. Sensory fibers from anterior 2/3 of the tongue here, again they pass along with these fibers that you have just described. They enter into the facial canal, pass the geniculate ganglion which have cell bodies of the taste fibers, and they reach the nucleus tractus solitarius. Clear? Now the last component will be the general somatic afferent fibers from the ear. Here, from the ear, these general somatic afferent fibers pass along with the posterior auricular nerve, the first branch of the facial nerve proper, enter into the facial canal. They have cell bodies in the geniculate ganglion, and they are projected to the spinal nucleus of the trigeminal nerve. So once this network is clear to us, Now we have seen what happens to the motor root, we have seen what happens to the parasympathetic fibers, sensory and general somatic afferent. Once this is clear, localization of facial nerve is very clear. Now if you look at the second chart, start from bottom, extracranial. So any lesion here is going to affect the facial nerve muscles on one side only. When the lesion appears above to this tympanomastoid, once the lesion is here, what happens? Nerve to the stapes is going to be affected. You are going to get a hyperacusis. Your salivation is going to be decreased because the salivatory fibers are affected and the facial muscles are affected. Taste is also affected. When you have a lesion at the level of the geniculate ganglion here, what happens? Your lacrimatory fibers are affected, so lacrimation is going to be disturbed. So that will help you in localization once you know the anatomy. And of course, once the nucleus is reached, cerebellopontine angle, you have 8th nerve involvement along with it. Nuclear level, again, we have had detailed discussion on what will happen at the pons. Supranuclear, we all know this chart. Both sides of the cerebrum innervate the upper part of the face. Lower part of the face is innervated only by the contralateral. So when you have a cerebral lesion here, a stroke or multiple, something is happening at the cerebral cortex here, the upper face is going to be spared while the contralateral lower part only is going to be affected. So that is how we differentiate between UMN and LMN lesions. Now all those celebrities I showed you in the beginning, we'll see what happened to them. Bell's palsy is very common. Almost all 70% of facial nerve palsies are Bell's palsies. Usually they have a viral prodromal history. The current hypothesis, that is all we can say, it is said to be due to herpes simplex virus etiology. Why? Because we have seen the tight facial canal in which the facial nerve passes. It is too tight. When you have an edema, inflammation there, the nerve doesn't have space to distend. There is ischemia and there is impairment of the functional nerve function there, and you get a facial nerve palsy. Usually, imaging is not needed when it is a classical Bell's palsy, especially in age groups 15 to 50. But anything outside that, and when this presents, it's usually complete within 20 to 48 hours. So you have a long-standing facial palsy, you have atypical age group, you don't have resolution. Almost 50% of these cases are going to resolve in 6 months, and 85 to 90% are going to resolve in 1 year. So if it doesn't, then you have to look for something atypical. As ophthalmologists during this tenure, what we have to see is we just have to ensure the patient has had proper eye care to prevent exposure keratitis. So even if you don't treat, these patients might improve. Angelina Jolie finally accredited her improvement to Chinese acupuncture, while Anupam Kher just said that he kept away from films and it improved. But if you see the patient within 72 hours of onset, give oral prednisolone in this dosage. Antivirals are generally not study-wise recommended, but some people give them anyway. Second will be trauma. When you look in the case of this young lady, when Taliban shot her, she had an injury to the petrous part of temporal. Now all these structures we see were in the temporal bone. So initially she went a surgical exploration, but then it was persisting, and many years later, 2 years later, they undertook her for nerve grafting, and you can see the final result is not so bad. It can also be due to iatrogenic, CP angle tumors, dissection, autologic surgeries can listen. What we have to rule out is this, infection. Justin Bieber took to social media how he developed Ramsay-Hunt syndrome. So always look for pain, always look for vesicles in outer ear, because if this is the case, you have to treat the patient with steroids, analgesia, and full dose acyclovir or valacyclovir, because if you don't treat this, almost 12% it is going to not, only 12% will recover, but if you treat with this conundrum, more than 50 to 70% recovery will be achieved. Then other infections, acute otitis media, mastoiditis, Lyme disease to be ruled out. Slowly progressing facial nerve palsies, rule out malignancies. Again, another indication for imaging. Facial nerve palsy can occur in children also. Rocky Fame, we are all, we look at his facial nerve palsy, but that was something he achieved by birth, due to forceps delivery. Then syndromic, genetic are all there. George Clooney, everyone speaks about his cute smile, but that was due to an acquired 15 years age when he developed a facial palsy. And last slide, bilateral facial palsy is almost never idiopathic. You always have to look for a systemic cause. Lyme disease, Guillain-Barré, diabetes, sarcoidosis, all have to be ruled out. So I hope facial nerve palsy, if it is Bell's palsy, you are safe, patient is safe, but rule out all other causes. Thank you.
Thank you so much, ma'am. You literally took us through our MBBS days. It was very nice presentation. Thank you. If anyone has questions,